Today we're going to be looking at the adrenal glands, which, as you'll know, is part of the endocrine system. And as we start to go through the adrenal glands, we're going to talk about the various hormones that are released from there. And so we'll touch at a very basic level on adrenaline and noradrenaline, because the adrenal medulla is basically it's a modified part of the sympathetic nervous system. It's functionally part of the sympathetic nervous system, and stimulus of the adrenal or stimulation of the adrenal medulla leads to the release of adrenaline and noradrenaline. It's about 80% adrenaline, 20% noradrenaline. And we'll also look at the controls, so the regulation of the release of cortisol, aldosterone, and the androgens, such as DHEA. So what causes their release and what some of the functions are. And we'll also think about negative feedbacks at the same time. First of all, we'll just quickly look at the adrenal medulla. Like I said, you guys already know this really easily, or a lot about it already. It's a modified part of the sympathetic nervous system. It secretes adrenaline and noradrenaline. It's embryonically and functionally part of the sympathetic nervous system, and it's receiving information from the brain via involuntary neurons in response to stressful stimuli, whether that's fear, anger, excitement, or stress. And it has a variety of effects. So it has metabolic effects, and some of those metabolic effects include glycogenolysis. So in the liver, it breaks down glycogen into glucose, or stimulates the breakdown of glycogen into glucose, which can then enter the blood and go to the tissues that require it. Stimulates in the adipose tissue the breakdown of triglycerides into fatty acids and glycerol. And the fatty acids obviously can be used as an energy source. And in the skeletal muscle, it breaks down glycogen again, but this time stimulates the release of breakdown of glycogen rather, so that glycogen or energy can be used for that skeletal muscle cell itself. It also has a variety of cardiovascular system effects. So it increases heart rate and stroke volume, causes vasodilation to the coronary and skeletal muscle blood vessels, obviously to deliver more nutrients and energy to them, bronchodilation for more oxygen, vasoconstriction of blood vessels to our non-essential tissues, such as GI, skin, and kidneys. So this is all this kind of stuff that you already know. So really just a quick set of review questions for you, just to remind yourself of it more than anything else. So press pause, read these questions, and I'll go through them in a second. So which of the following regarding the adrenal medulla are true? Does it produce steroid hormones? No, that is incorrect. The adrenal cortex produces the steroid hormones. Remember, they're made from cholesterol. And adrenaline, of course, is a tyrosine derivative. And it is, just so to remind you, it is water soluble, unlike the steroid hormones, of course, which are lipid soluble. Has cortisol as a major secretory product? Obviously, that's incorrect because it's adrenaline and noradrenaline. Decreases its secretion during exercise? Again, that's incorrect. You activate the sympathetic nervous system during exercise. Is formed by a modified portion of the sympathetic nervous system. Obviously, that is correct. And secretes adrenaline, but not noradrenaline. And obviously, as we've said many times, that is not correct because it secretes both adrenaline and noradrenaline. Remembering, of course, therefore, that noradrenaline acts as both a neurotransmitter and a hormone. Which of the following regarding adrenaline are true? It constricts the respiratory airways. That's incorrect. It bronchodilates them, so it dilates the respiratory airways. It elevates the concentration of blood sugar. That is true. It does elevate blood sugar levels. So if people have tumors secreting adrenaline or noradrenaline, so that's a pheochromocytoma, that elevates blood sugar levels and, of course, can therefore lead to diabetes mellitus. It stimulates the glycogenolysis in skeletal muscle. Yes, that is correct. We talked about that. It inhibits lipolysis. That is incorrect because it stimulates lipolysis. And it inhibits hepatic glycogenolysis. And that is incorrect because it stimulates hepatic glycogen breakdown. Okay, so let's have a little bit of a look at the adrenal cortex itself. So we already know that the adrenal gland sits on top of the kidneys. The inner part is the adrenal medulla and the outer part is the adrenal cortex. And the adrenal cortex is further broken down into three parts, which you can remember very nicely with GFR. So you've got your zona glomerulosa, that's your G, that's involved in the synthesis of aldosterone. Your zona vesciculata, that's your F, that's your cortisol, and the zona reticularis, which is your androgens, such as DHEA. And so, like I said, that's your GFR, that's the way I remember it at least. And then you've got adrenaline being released from the adrenal medulla. And if we're crudely looking at a very simple level about how the hormones, these three hormones, are made in those various different parts of the adrenal cortex, they all start with that cholesterol backbone. And then through stimulation of enzymes that we'll talk about in a few minutes, we get the formation of progesterone, which is an intermediate. And then that intermediate can then go on to form aldosterone, cortisol, or DHEA, your androgens. And so other androgens as well as DHEA are things like androstenedione as well. And androstenedione is a precursor for both estrogen and for testosterone as well. And now we're going to be thinking about, right, what's the regulation of cortisol synthesis? So, as you already know, cortisol is the long-term stress hormone. And any stress, any type of stress, is a powerful stimulator of cortisol production. Now, that might be physical, such as hypoglycemia, temperature changes, infections, surgeries. It might be psychological. So, for example, exams. And so if we're looking at these stresses all work at the level of the hypothalamus. And likewise, it's also released in diurnal rhythm. Just quickly, in your heads, when do we get the most cortisol being released and when do we have a low? So you should be seeing a peak at first thing in the morning as cortisol release is released in preparation for the stresses of the day, and it's at a low at last thing at night. And many hormones have diurnal variation. And so anyway, any of these stimulus are coming in there, acting at the level of the hypothalamus, because it's involved in the hypothalamic pituitary axis, releases CRH, which is corticotrophin releasing hormone, passes down to the anterior pituitary, which stimulates the release of ACTH, so adrenocorticotropic hormone, and that acts on the adrenal cortex to cause the release of cortisol. And as with all of our endocrine systems, there's a nice feedback loop, and this negative feedback loop, the cortisol acts on both the anterior pituitary and the hypothalamus to inhibit ACTH and CRH release respectively. And so as we've already talked about in an earlier slide, the ACTH is actually increasing the activity of that desmolase, if you remember, and therefore the cholesterol availability and its conversion into pregnenolone. But it also helps to stimulate some of the enzymes involved in cortisol and therefore androgen synthesis. Now remember as well that cortisol is a fat soluble hormone, so therefore it binds to protein within the blood, so it can get carried around the blood in that form. And it's mainly bound to the cortisol binding protein transcortin. So if we're looking at some of its effects, so it has metabolic effects, and some of those metabolic effects include the increase in glycogen levels, so it stimulates glycogenesis, but it also increases blood glucose levels, and increases blood glucose levels by stimulating gluconeogenesis. So therefore, it's helping to protect against hypoglycemia. So why do you think we might want to stimulate glycogenesis? Why do we want to increase our glycogen stores? Well, it's helping to protect against hypoglycemia in a way, because think about it, an injured animal is unlikely to feed properly. And if it's unlikely to feed properly, it still needs those glycogen stores in case it suddenly gets attacked by another animal and has to sprint away. That's the kind of way I remember that it works. It's a stress thing. You increase your blood glucose because you're protecting against hypoglycemia, but you're also increasing your your glycogen stores, so that if you need to get away from an enemy very quickly, you still can. It also works on proteins, and it catabolizes proteins, and that, of course, is leading to an increase in blood amino acids and therefore increased glucose production. But those amino acids, as they increase in the blood, they also could be quite useful in repair of injury if it's an injured animal, again, for example. It also increases lipolysis and decreases lipogenesis. And again, that increases our free fatty acids. And therefore, with those increased free fatty acids, they could be used as a nice energy source for most of our tissues. It's also involved, and we've been talking about stressful, so how the stress is involved in this. And I talked about an injured animal. So you make your glycogen stores, your proteins can help to repair the tissue, the fatty acids can be used as an alternative energy source. But also cortisol has vascular reactivity, and stressed animals tend to go into circulatory failure if cortisol is not released. So if they're prevented from being released, so it's involved in that vascular reactivity as well. And it does this by having necessity or increasing the responsiveness to adrenaline. And as you already know, so it also has anti-inflammatory and immunosuppressive roles. So it inhibits many facets of the immune system and inflammatory responses, in particular in large doses. And of course, the corticosteroids are used clinically, for example, in patients following transplant. But of course, that increases susceptibility to infections, but also for asthmatics, for example, to dampen down that inflammatory response within the airways. So really, at physiological amounts of cortisol, they help to keep the inflammatory and immune system responses in check. Other roles include the maintenance of normal skeletal muscle and cardiac muscle contractility. They help to maintain GFR through aiding in water secretion, because they kind of helps in inhibiting ADH secretion, for example. So let's have a little look at a quick review question, not a particularly tricky one. It's just about the release of cortisol. So have a little read. Only one of these is correct. Have a little read and what's your answer? So the release of cortisol is regulated by other hormones. Which of these hormones is correctly matched with its origin and function? So which is it? 1, 2, 3, or 4? Yeah, it's 4. ACTH is secreted by the anterior pituitary and it stimulates the adrenal cortex to stimulate cortisol. Okay, so back to this same slide again. We've seen this a few times now, and what we're going to focus on is as aldosterone. And as we've talked about, ACTH stimulates enzymes involved in cortisol and androgen synthesis. And now we're going to talk about aldosterone. ACTH only has a very minor role in regulating aldosterone production because it doesn't appear to stimulate the enzymes required or that are unique in the aldosterone pathway. So aldosterone is required for life. So the absence leads to death due to circulatory failure. You can't maintain blood volume and blood pressure long-term without aldosterone. We've talked about its control of release, its response in response to the renin-angiotensin-aldosterone system, the RAS system. And therefore, what stimulates that? Well, hypovolemia or hypotension, leading to a reduction in your GFR, reduction in renal blood flow, reduction in GFR, and therefore that's detected. And we get the release of renin. And it's also a direct release in response to high plasma potassium, as we've already talked about. Some of its functions: sodium reabsorption in the renal distal tubules, helping to control blood volume and therefore blood pressure, and potassium and hydrogen excretion in the renal distal tubules, again maintaining plasma potassium and acid-base balance. So it's important also to note, if you have an increased rate of potassium secretion, that decreases hydrogen secretion and vice versa. So therefore, in an acidosis, for example, more hydrogen ions will be secreted, which will then lead potentially to an increase in potassium in the blood and vice versa. So you guys know this very nicely, so we'll run it very, very quickly. So if you have reduction in renal perfusion, for whatever reason that might be, stimulates the release of renin. That acts on angiotensinogen, release from the liver to produce angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme within your capillaries within the lungs. This has lots and lots of roles, only some of which we're going to look at here. So it stimulates the thirst center to make your drink, stimulates the release of aldosterone, which causes sodium and water reabsorption. It stimulates arterial vasoconstriction, ADH release, which of course leads to water reabsorption. It also acts at the level of the proximal tubules to cause the reabsorption of sodium and therefore water. And of course, all of these things together increase your blood volume and increase your blood pressure. So this is stuff that you all should know in quite depth by now. And so we've got a really quick question for you. Which of the following are true regarding a Conn syndrome? So more than one could potentially be correct. Now, Conn syndrome is actually an underdiagnosed but a relatively common cause of hypertension. I think it's around about 1% of the population, or the hypertensive population, have Conn syndrome, and it's caused by an aldosterone excess. So which of those are correct in this case? Press pause, and we will go through what may happen in Conn syndrome. Okay, so we have Conn syndrome. We have too much aldosterone. Blood potassium levels increase. That is incorrect, of course. With excess aldosterone, we excrete more potassium, so blood potassiums are more likely to go down. Blood hydrogen levels increase. That's also incorrect for exactly the same reason. It stimulates hydrogen ion excretion and therefore potentially an alkalosis. Oh, damn, I've just given you the answer. Alkalosis, that was very stupid of me, wasn't it? Oh, use your brain. Alkalosis, yes, that one is obviously going to be correct because we excrete more hydrogen ions and therefore you're more likely to get an alkalosis. I can ask you whether it'll be a metabolic or respiratory alkalosis. Hopefully you'll get it right. It's not a hard one. Yeah, metabolic alkalosis. Please tell me you didn't say respiratory. Blood sodium levels decrease. No, that's incorrect. They are going to increase because aldosterone causes the retention of sodium. Blood volume increases. Yes, that is obviously increased. Obviously correct. Sodium retention, water follows, therefore blood volume increases and therefore blood pressure increases. So we'll just have a little bit of a look at a couple of disease states now, at a very basic level. And so we're going to look first of all at adrenal cortex hyperfunction. Now, adrenal cortex hyperfunction, and we're going to look at Cushing syndrome. And there are lots of symptoms of Cushing syndrome. So central fat deposition, abdominal striae, so stretch, thinning of the limbs, easy bruising, osteoporosis. There are lots and lots of symptoms of Cushing's. And so what I'd like you to do, first of all, in the Cushing syndrome, which is just any, as you'll know, the difference between a syndrome and a disease. So this is any cause of hypercortisolemia, the most common, which is people taking too much in the form of medication. So what levels of cortisol, CRH, and ACTH would you expect in a patient with Cushing's syndrome, so hypercortisolemia? So in this case, if it's primary hypercortisolemia, so in other words, there's something wrong with the adrenal glands, so you may have an adrenal gland secreting adenoma, for example, or secondary due to a hypothalamic disorder, or secondary due to a pituitary disorder, in which case it is called Cushing's disease. Okay, so Cushing syndrome, remember, is just a selection of signs and symptoms. Cushing disease is a pituitary adenoma secreting ACTH, which kind of just helped you there again. Anyway, so primary, have a little look at this table and complete it. I just want high, low, or normal in each case. Okay, so you have primary hypercortisolemia. What do the cortisol levels be? Well, clearly they are going to be high. It's hypercortisolemia. It doesn't take a genius to work that one out. So you've got an issue with the adrenal gland secreting too much cortisol rather. So an adenoma, for example. What will your ACTH levels be? Low, and your CRH low. And that's because you've got that negative feedback. You've got high levels of cortisol being uncontrollably secreted from the adrenal cortex, meaning that you have a lot of negative feedback at both the level of the pituitary gland and at the hypothalamus. Now we've got a secondary cause of hypercortisolemia. In this case, it's Cushing's disease. So this is an ACTH secretor. So our ACTH levels, of course, will be up. What will our cortisol levels be? Yeah, they will also be up because we, of course, are stimulating the adrenal gland to produce the cortisol. And the CRH levels, of course, will be low because the cortisol is acting as a negative feedback onto the hypothalamus. The negative feedback, of course, doesn't work at the level of the pituitary in this case because it is out of control. It's an adenoma secreting ACTH, so it's not subject to the same control mechanisms as in health. So secondary now down to hypothalamic. So we've got an issue with the hypothalamus. So we're secreting lots of CRH. So the CRH goes up, therefore the ACTH goes up, therefore the cortisol goes up. And again, the cortisol negative feedback isn't going to be working because we've got so much CRH and so much ACTH being secreted. Okay. So now we've got adrenal cortex hyperfunction. We're thinking about cortisol hypersecretion. So we're thinking about Cushing's. And I want you to really think about what are some of the consequences of chronic cortisol hypersecretion. So what are the consequences of hypoglycemia and insulin resistance? So glucocorticoids, as you can see down in this little table here, they stimulate gluconeogenesis. We know about that, increased glucose synthesis. They stimulate lipolysis and proteolysis. They also increase insulin resistance. From memory, so don't quote me on this one, but from memory, they decrease the synthesis of the insulin receptor, therefore leading to insulin resistance, and they dampen down immune function and inflammation as well. So, what are the effects going to be in terms of hypoglycemia and insulin resistance? Well, of course, you're going to be thinking about diabetes mellitus. What about proteolysis? What are some of the consequences of that? Okay, I'm going to run through these. So I hope you pressed pause so you could think about some of those signs and symptoms. We touched on a little bit of them earlier. So it might lead to muscle wasting, so muscle weakness, bone matrix loss and osteoporosis, weak pliable skin, so striae, blood vessels becoming weaker, so therefore easier bruising, and poor wound healing because of decrease in the amount of collagen. So those are all some of the symptoms that people may get, signs that people may get. And then there's also fat redistribution. So you might see central obesity, you might see a buffalo hump, so at the back of the neck, and a moon face as well. And in women, you may see hirsutism, and that's because of that ACTH stimulation. Remember, you may have an excess in ACTH trying to stimulate the release of cortisol. If it's Cushing's disease, for example, excess ACTH leading to excess cortisol, and that ACTH will stimulate DHEA and therefore androgens and hirsutism, for example. So this is just showing some of those other signs and symptoms that you may get. So you can start to put it all into context. So there's baldness and facial hirsutism, as we talked about in females. Acne, that moon face we talked about. What didn't we mention? Muscle weakness, easy bruising, skin thinning. So most of them are there, but also hypertension. And now cortisol actually has quite high affinity for the aldosterone or the mineralocorticoid receptor. However, it's processed to cortisone at that receptor, and that cortisone doesn't bind to the receptor. However, with excess cortisol, that processing mechanism is overwhelmed, and so cortisol remains and it can bind. So therefore, like I've said, cortisol in excess, because it can no longer be fully broken down to cortisone, which doesn't bind, it can now bind to the aldosterone receptor, enhances the activity, and at the same time, it enhances the activity of adrenaline, remember. So we're thinking it's binding to that aldosterone receptor, we're getting a bit more reabsorption of sodium and water. It's enhancing the activity of adrenaline, so we're thinking about vasoconstriction and increases in cardiac output, all of which are starting to lead to hypertension. And as we've said, the most common cause of Cushing syndrome is Cushing's disease, which is an ACTH secreting adenoma from the anterior pituitary. Treatments, things like surgery, radiation, and a variety of medications as well. So we're going to go into the opposite direction now. We're going to go into adrenal cortex hypofunction. And that's where people will have Addison's disease. The most common person with Addison's disease was JFK. Though there may obviously be others. And what you're looking at in these images is just some hyperpigmentation. And I'll explain why that hyperpigmentation comes in a second, because I don't want to preempt one of my later questions. So the main cause is autoimmune destruction of the adrenal cortex, not the adrenal medulla. And if the adrenal cortex is destroyed, what would happen to the following hormone levels? Would they be increased, decreased, or within the normal level? So remember, the adrenal medulla remains intact, and those autoantibodies destroy the adrenal cortex. So press pause and have a think about what will happen to each of these levels. So cortisol, what will happen? We've destroyed the adrenal cortex, so cortisol levels go down. ACTH levels now will, of course, go up, as will CRH. There's no negative feedback at the level of the pituitary or the hypothalamus, because we don't have that cortisol, and yet the stimuli are still coming in for its release at the level of the hypothalamus. Aldosterone, what will happen to that? Well, we destroyed the cortex, so that aldosterone levels will start to decrease as well. DHEA, they will start to decrease as well, of course, because that's where they're made, and adrenaline will remain in the normal level. So what are some of the possible consequences of adrenal cortex hypofunction, so in Addison's disease? So, for example, the decreased cortisol and the decreased aldosterone, what can they do? So if we're thinking about decreased cortisol, you'll be thinking about decreased stress response, because remember it's involved in immune and inflammatory responses. You might be thinking about hypoglycemia because it enhances or increases blood sugar levels. And you may be thinking about weakness and fatigue as well. And if you're thinking about decreased aldosterone, of course, you're thinking about low blood volume and low blood pressure. Some of the other symptoms that you get, so ACTH actually has melanocyte stimulating activity, so that can lead to this, and I showed you in the first image, that can lead to this hyperpigmentation that you can see in the gums, you can see it in the palmar creases, and also in the nails, and that's that ACTH stimulated, or ACTH having melanocyte stimulating activity. Some other of the symptoms that we've talked about include anorexia, didn't talk about that, and that's just your reduced appetite, abdominal pain as well, that bronze skin that we talked about, and the weakness is due to the muscle breakdown. And of course, fatigue, you're starting to get hypoglycemia, so you don't get that energy. And so it can be quite serious if people have serious bouts of Addison's disease when it kicks in, where they can get significant hypovolemia and low blood pressure. Treatment, of course, you may want to increase your salt intake, may want to be taking hydrocortisone, for example, so corticosteroids, and fludrocortisone, so your mineralocorticoids as well. Okay, so some review questions for you. So have a read of these and then we shall go through them. Which of the following are true regarding a Cushing syndrome? Deposition of fat in the face, neck, and abdomen. Does this take place? Yes, it does. I'm not sure of the mechanism. I'm not sure why that happens, but it does. A low blood glucose. Is that likely in Cushing's? No, it's more likely to be a high blood glucose. Low blood pressure. That's also incorrect. You're more likely to have high blood pressure. Muscle weakness. Yeah, that is correct because you get a breakdown of your protein, remember. Which of the following are true regarding Addison's disease? Blood pressure increases. No, blood pressure can drop quite dramatically at times. High blood glucose is a common consequence. That's obviously incorrect because it's a low blood sugar. Blood volume decreases. Yes, that is correct. Androgen levels increase. No, that's not correct because remember, get autoimmune destruction of the adrenal cortex, and that's where your androgens are made. ACTH levels increase. Yes, obviously, your cortisol is dropped, therefore your ACTH goes up in an attempt to stimulate the adrenal cortex to make cortisol, but the adrenal cortex is dead, so it can't make the cortisol, so the ACTH goes up. Hope that made sense. I said it very fast in a weird way. Anyway, that is the end of this session, I think.